Good morning, you guys. I am sitting all alone in my office. I really wish I had somebody here to talk to. It makes it more fun than just talking to myself. But I hope you guys are having a good Thursday. Those of you guys that are at clinical, stay awake, be engaged, be happy. And those of you guys that have tomorrow, try to get some sleep tonight. So I thought I would just answer a few questions, maybe address the objectives for our pediatric GI. So bear with me 1 second while I pull up the objectives for this. And we'll just talk a little bit about some of the questions that you might have in differentiating some of these motility disorders and some of the things that we talked about. I only have, I think this is unit 8. Let's see here if we've got the, nope, it'll be unit 9, sorry. I only have about 12 questions or so on the test. So you'll have the adult GI, the Peds GI, and liver. And liver takes up a good portion of the test. Alrighty, so we've got these objectives here. We'll just pull these up. Maybe if they want to cooperate with me. Okay. All right, so for our pediatric ones, we want to talk about objective number 5, clinical manifestations and therapeutic interventions for a child with pyloric stenosis. So is this a sick child? Do they look like they present with a fever, high white blood cell count, or is this something that they're born with that can be just cause an obstruction? So this child won't present as being ill with the exception of dehydration. So think about what things look like for your dehydration and what pieces you would assess for, because that's really going to go into play with this child may not be gaining weight, may be really dehydrated because they're vomiting. So they have that pylorus muscle that's tight and stenotic at the base of their stomach. And they're not able to move their fluid, move their food and fluid through very well, so that they have, sorry, I lost my place here. There we go. So that they have the nutrients that they need. Then, so it says clinical manifestations. So that's the projectile vomiting. That's a child who's hungry in between. So this little kiddo they vomit and vomit and vomit, and then they're like, all right, who's going to feed me next? They need to be burped a lot. And so think about things that would make you know that your surgery went well, or that things were working out for this child. Think about your concerns. Then your therapeutic interventions obviously is going to lead off with surgery. And then you're going to look at your aftercare and what you need to do for that child to be able to see that they're healthy, see that they're going to keep down their food, see that they're going to be able to progress and gain weight. You might even need to give them some IV rehydration to kind of catch them up a little bit. Number 6, let's see. Nope, that's GI bleed. That's Vicky. So number 7, clinical manifestations and therapeutic interventions for a child with a bowel motility disorder. So our motility disorders, those were our Hirschsprung's and gastroparesis, intussusception, and imperforate anus, and chronic constipation. So there's a lot of different clinical manifestations here. So we'll just kind of break them off in little chunks. So you had your chronic constipation. What does that child look like? If you have chronic constipation, do they have a distended belly? Do they have hypoactive bowel sounds? Do they look sick, or are they feverish or have a high white count? Those are kids that aren't sick, they're just constipated. And so think about the things that go into that, and maybe some of the education that we need to do with these families in helping them manage this. Therapeutic interventions, so they will often need higher fiber, higher increased mobility, lots of water. Sometimes they might just need a touch of juice that has, because juice has a lot of sugar in it, it'll draw water into the bowel and it'll help loosen things up a little bit. Some of them might need to be on Miralax. But looking at their diet and looking at their mobility, all of those things that have to come with constipation and immobility that you guys know about are going to be pieces of education and interventions that you'll do for that. The next one was Hirschsprung's, and Hirschsprung's is the one where the ganglion cells aren't present in usually the rectosigmoid colon. And so that's where we will have no peristalsis, or very slow or very little. And so it's going to back up. And so you will actually have constipation issues also, but just for a different cause. Surgery is required, and usually they will do a colostomy, and they'll rest part of the bowel once they'll cut out part of that rectosigmoid colon, and they'll attach the rest of the colon down to the rectum and let that rest while it heals. They need, I'm trying to think, they will do a rectal biopsy to see if there are ganglion cells in that part of the colon before they go and just resect it. But on an x-ray, if you look at the little video we watched about the guy who had his bowel removed, it'll show an x-ray that has a really skinny little end of the rectosigmoid colon. And that's pretty indicative of that. They have the megacolon that's above it where you have lots of stool that's backed up. The next one was intussusception. And with intussusception, I had a student tell me one time the two S's of the middle of the word fit together, almost like a link, and it would just be like the two telescoped pieces fit together, and they just kind of slide. One just slides inside the other. So that maybe that's a good way to remind you about the telescoping bowel. It cuts off blood vessels, and so what are you going to see with this kid? They're going to be in a lot of pain. It'll come and go as peristalsis comes and goes. And so really get a good history. You need to get a good history on all of these. Anything that has to do with intake and output, you need to see what's going on with them more so than just what's coming out. And see what that relationship is. With the intussusception, where it cuts off the blood flow, you can have necrotic piece of bowel, and they will have some bleeding into their bowel, and it mixes with the mucus in the bowel and makes kind of that currant jelly look to their stools. So when you're asking those questions in your history, ask about what the color and consistency of their bowel movements too. Then we had gastroparesis. That's where the stomach isn't emptying well. And so what does that child look like? They get full really easy. They vomit a lot. On an x-ray, it might show that their stomach is really full, but there isn't much that's in the small intestine or in the large intestine down to the colon. To make sure that they know that things aren't moving, they might try something like erythromycin that'll start peristalsis up and see if that's helpful. And that would be one of your therapeutic interventions. The last one was the imperforate anus, and that's where they don't have an anal opening. And so sometimes they have little pockets called fistulas that go up out the vagina or out through the scrotum, out through the vas deferens. They kind of are out near the vas deferens, but out the penis. And they'll have stool coming out of these areas. So if you have a small child that doesn't have a rectal opening, but has a scrotum that is a little bit enlarged, and there might very well be a fistula that needs to be drained and cleaned out and closed off when they do that anal surgery. And then they will go ahead and make an opening. So first they'll make an ostomy, then they'll make an opening, and they'll bring down the rectum, like a rectal pouch, and connect it to the anus, and then let it rest. Once it's healed, then they'll go ahead and take down that colostomy and put it all back together. Because that can cause some chronic constipation issues for, not really chronic, but cause some constipation issues for a little bit of time. They will often, these kids that have these surgeries will often be on something like a stool softener or some Miralax or something for a little while until that bowel is a little healthier and healed. Identify clinical manifestations and therapeutic interventions for a child with gastroenteritis. So that's number 8. Gastroenteritis is your nausea, vomiting, diarrhea stuff. So clinical manifestations, what does that kid look like? They come into your office, they're sick, they're dehydrated. What are those dehydration pieces? When you're doing your assessment, look at their fontanelles. Look at their little face. Are their eyes sunken? Do they have tears when they cry? If you're going to start an IV and they're crying and they don't have any tears, that's a really dry kiddo. Parents might say that they haven't changed a wet diaper in a while. So really think about what they look like. They look sick. They may often have a fever, and because they're fighting something off. And so they look different than a child with pyloric stenosis who's dehydrated, who otherwise looks healthy. They're not pale, they're not feverish, but they can be dehydrated. So think about those dehydration pieces when you're thinking about your entire history. Then therapeutic interventions. So if you have a kiddo that has gastroenteritis and they are very dehydrated, we're going to start some IV fluid. But to be able to go home, they have to PO. And if you start PO food or fluids or whatever, and they immediately start vomiting or having lots of diarrhea or something like that, you really need to back your truck up and stop what you're doing, stop feeding them, and give them some more IV fluid. And then once they have rested their bowel a little bit and rested their belly, then try again with some clears and just advance them slowly and see how fast you can get them ready to go home. Then our next, our next objective, my screen went to sleep. Sorry, one sec. Nine, identify clinical manifestations and therapeutic interventions for a patient with appendicitis. So with the appendicitis, these kids were kind of back to like our gastroenteritis. They're sick. They have a fever. They have a white count that's high. They're in a lot of pain. So what do people do when they have a lot of abdominal pain? They kind of bend over, hug their knees, maybe lay on their side. They're really kind of curled up in a ball. You just need to uncurl them just enough that you can do some gentle palpation and see if you've got some rebound tenderness in that right lower quadrant. You can also bump the bottom of that right foot and see if you can cause a little bit of rebound tenderness, I guess, there. So don't make them sit up straight or open up so that you can start an IV. See if you can be creative about how else you can take care of them and leave them in that position. Surgery is required, so think about your post-op things. What do you do for this kiddo? Once their vital signs are stable, we're going to do a good assessment with their bowel sounds, especially because they have sleepy bowels if they have been manipulated. So don't start advancing their diet too soon. Make sure that you've got at least some bowel sounds for a few clears. And then active bowel sounds before you get them to a regular diet. Hypoactive can be kind of advancing, but if you have no bowel sounds, stick to a few ice chips, maybe a swig or two of some water, but just to kind of wet their mouth and make it so that they so that they're not so thirsty. Then get them moving. Get them up and moving. The mobility will help move their bowels along. Okay, so get them woke up a little bit more, because what immobility, just kind of sitting around and having pain meds and everything will do. It won't get things going like it needs to, and they can end up with an ileus. So those are just kind of some touch points, I guess, on your clinical manifestations and therapeutic interventions. If you're struggling with making connections with that, I would suggest maybe setting up a little grid like you did with your pediatric heart anomalies, and then maybe drawing some pictures. Some people that have come to me for some help have asked about that, and that was something that helped me in school. I'm not a great drawer, but be able to draw those pictures out and be able to see what some of the differences are in my drawings. And then when I went to take my test, I would be able to kind of close my eyes and see that picture and remember some things that I may not have remembered before. So I think that's it for our little Q&A. And so I hope you guys have a good day and a good weekend, and I will see you Monday.